Thank you. I think that you did a wonderful job of putting a face on the patient that is out there that needs help, Mike. Now we'll take questions from the audience. Does anybody have a question? I am totally amazed. Yes.
Yeah, I belong to an organization that's going to...
Could you come up here for a minute? I'd like to make sure we get you on tape. Just no, just stand close to mine.
I belong to an organization that's doing a vigil for the about 550 to 700 people a year who died because they don't have health insurance. Robert Wood Johnson put out a report called Dying for Health Care. And when I hear DHH speak about the undeserving poor that may be flooding into Medicaid, I think about the grotesque immorality of killing 700 people a year by withholding health insurance.
Your question, sir. Your
Why
question?
is it so immoral? How's that?
Okay, Calder.
First of all, I take offense to your question. I'm not immoral. I think that's out of line. But I will address the issue that you raise. And that is that...
Deal with values. That would be wonderful.
So we have a set of values that we at any government agency I think needs to abide by, and that is to provide services as efficiently and effectively as we can with the resources that we've been entrusted to. And I think that as a government agency, that is what we strive to do. I think that there are a lot of things that are easy in terms of, your aspirations of giving things, services, but we are constrained by resources, obviously. And so when we look at programs, and we don't just look at it in terms of state dollars, we also look at it in terms of the federal resources, because they're all taxpayer money, and how we can provide care to people in the most effective way. I don't think this administration believes that just simply expanding Medicaid is the answer to that. Medicaid has its own set of problems. It's a program that's not set up or designed really to care for that population. I think clearly we have challenges today in our healthcare system. I think all states do. I think many countries do. And we are trying to address those in the best way we can. We just heard about some of the problems with accessing the public system, and they're true that we have had many problems in that system in terms of access. Those problems are improving. We've cleared in Baton Rouge with the partnership with Our Lady of the Lake, one of the first accomplishments was clearing a backlog of over 1,700 prescriptions that were waiting to be filled. They're now being filled in real time, in 5 to 10 minutes, rather than taking weeks to get to the patient. Those are the sort of efficiencies that we're gaining at the same time that we're spending $120 million less by better managing that system of our own funds. So we look at all those things when we take those decisions into account. We try to figure out the best path forward to care for the people as effectively as we can with the resources that we do have. Thank you.
I'm unconvinced.
Talk after.
We have another response here. Fred, do you want to address that?
I just mentioned to Gene, this prescription example is one that particularly bothers me because we established, the public system set up a prescription benefit. The patients that Dr. Ralston talked about, we recognized years ago coming to the public system, they didn't have insurance, we could write prescriptions for them and they would not get their prescriptions filled because they couldn't afford it. And so many people in the public system spent time working with the pharmaceutical manufacturers to set up a program whereby patients could reliably get their prescriptions filled. They had a program where you could do it one by one, and you get 30-day supply. Well, we set up a system where we worked with the manufacturers to say, look, let us screen everybody financially. You take our word for it. You bulk ship the drugs to us. We'll make sure they get distributed to people who are in the right category, but not to others. And so we were doing over $30 million a year in free drugs to people throughout the public health system that would not otherwise have access to drugs. And we did studies proving that people with diabetes were better controlled after the institution of that system. Now what happened was in the transition of care from Earl K. Long to Our Lady of the Lake, which is a wonderful partner, but in that transition, services were dropped and they had to get picked back up again. So this issue of, now the people are getting prescriptions is a little bit misleading because that program had been going on for many years by good people in the public system that set that up to benefit patients. So come up with a better example, Calder.
I've got many examples.
Well, as a former Roche salesman, I can tell you I was the first pharmaceutical rep, and Roche definitely provided medicine to the doctors to give to their indigent patients. So did Glasgow. Henry,
Yes. I'd just like to ask Dr. Mike.
come up here so we can hear you.
Since you spoke about the clinics that you doctors goes up part of Baton Rouge clinic myself. My doctors, all of my doctors go there too. But you spoke about the service that you all give to people that may not have a doctor, can't get medicine. Is there any way that this is being advertised so that the people who really don't know about this, I'm glad to hear you say that, because I run into a lot of people that don't even have a doctor and can't go nowhere and don't have any money. So I might can start sending them to wherever your clinics are, wherever you might be in some cases.
Well, thank you. Yeah, the answer is no. There's actually, and that's not the only organization. So the organization I talked about, Voluntary Health Corps, we only see referrals from the hospitals and the emergency room. Again, part of the purpose of this organization is to unclog the emergency room. So these people would end up going back to the ER for care that they really don't need to use the emergency room for. So we don't see people that, we continue to see them until they can get into the private clinic or the public clinics, but that you can't just come off the street. You have to go to the emergency room to come see us, which is kind of crazy. There is an organization that Bill Cassidy helped start back 10, 15 years ago called Greater Baton Rouge Community Clinic. The problem with that organization, I was on that board and still work with them some, but you have to be working poor. So you have to have a job for the past 6 months, making at least 200%, less than 200% of the federal poverty guidelines, and have 30 hours per week in W-2s, et cetera. So there's a lot of requirements that people don't meet. So the Greater Baton Rouge Community Clinic is a resource for people without insurance that are working and just can't afford insurance.
Thank you. Nikki?
So you brought up an interesting.
No, no, you can't hold it. Just,
You brought up an interesting point about the 30 hours per week, and this administration obviously has had a very big focus on economic development. And there was a business report forum on healthcare earlier this year, and one of the things that came out of that discussion was there was about 400,000 people that the Medicaid expansion would cover that are working, that work for companies with more than 50 employees. And so as we're seeing these large companies cut back workers' hours to 30 or less, and what is the impact? Because my understanding from the forum was that there's a big impact to business, negative impact of not taking the Medicaid expansion. So I'd appreciate your comment.
Well, I think there's two components to that question. The first is the impact to businesses that really was came originally from a report that came out from one of the Jackson Hewitt, one of the national taxing authorities, and was really presenting sort of this worst case scenario that if every company dropped their coverage and shifted everybody that would have otherwise been eligible for Medicaid, and they paid a penalty, that's what the total exposure could be. It's really not a realistic example, and I don't think we should really consider in terms of it was one of the major problems with this law is the incentive that it creates for companies to scale back hours or to not grow beyond the threshold of 50 employees that then triggers them to be required to provide insurance. Now that provision has obviously been delayed until 2015 with the employer mandate. But we already in this country, it's very interesting if you ever see a graph of the size of all American businesses in terms of employees, there's a huge cliff right at the 50 mark because there's a ton of federal regulations that kick in right then. And so by adding this additional component of now being required, to provide comprehensive insurance at that point, there's a lot of companies that are right around that mark that are not going to grow any further. They're going to scale back. They're going to let people go to get underneath it. And I think it's a really perverse incentive that we've created with this law, both for the employee that have this incentive to push people down underneath 30 hours or down underneath a certain income level so that they qualify for Medicaid, or not to grow beyond 50. And I think that's an area of this law that absolutely needs to be revisited.
don't sit down, Carter.
Okay.
I've got one coming up for you. We've talked about diabetes and we've talked about heart conditions, but what about HIV? Baton Rouge has one of the highest levels of HIV, and this is some of the most economically challenged people in the country. What is DHH doing to help the people with HIV in our community and in the state?
That absolutely is a major challenge. I think it's a major challenge for for many states, but in particular, in Louisiana, both Baton Rouge and New Orleans have very high incidences of HIV and AIDS. And our Office of Public Health, really works very hard in those communities. They have clinics, and I'm afraid I'm not the expert on those services, and I'm happy to get information back from our Office of Public Health about those resources that are available.
Well, if you will send me an email, everyone that signs up with their email address over there, I will forward his answer to you if you are interested.
I do know that they are working right now. We're one of the first states, we are the first state in the nation that's established what they call Louisiana Public Health Information Exchange, and they're using that. It's really cutting edge in terms of them being able to capture data, track individuals, be able to direct resources to communities in spots where they need it the most. And it's really exciting things that they're doing. So I'll be happy to share that with Gene and get that out to the group. Thanks.
Hey, Gene, can I say something from a small business perspective?
Don't you, so everybody can hear you.
I'm in an association that represents 450 small businesses that provide in-home.
Could you tell us what that organization is, please?
Yeah, it's called the Supported Living Network. The agencies are over 50 employees. Generally, they provide in-home support to people with disabilities.
Speak into the mic.
So they can stay in their own homes.
Speak to
right?
it.
Okay. All right. So they mainly have over 50 employees. They also have people who would almost all be eligible for the Medicaid expansion. Almost all. They don't make $15,700. They don't as a family make $30,000. But agencies like ours are going to go out of business without the Medicaid expansion. My wife's bill in 2015, unless things changed and we got the expansion, would be $300,000 additional dollars. Some people would be hit with $1 million bills who wouldn't have to pay a penny if DHH would relent and actually start talking about expanding coverage instead of driving businesses out of business.
Next time we want a question. Kelly, did you have a question? Okay, no question. Well, one of the, okay, sir, would you come up here? I need you to speak into the mic because we are recording this. And a question.
Come on, let me make a statement.
I'd like to address a question to David Hood
Truly.
about a policy matter for the long run. In the long run, should employer-supported health care have a role? And are we phasing it out, or are we keeping it forever in the present policy direction?
Well, that's a great question, and I think the answer is, at least for the immediate future, we're stuck with employer insurance. And, of course, it served some people very well, but the point is that it only serves a portion of our population. And I think that it would be best for companies, it would be best for those people who are insured and those people who are not insured to simply get rid of not only employer insurance, but all the other various blocks, and complexities that we have in this particular system that we have in the United States. And in these other countries, and Gene asked me about them, what percentage are fully covered? Well, they're all fully covered. And they all have one healthcare system, basically. Maybe one or two have more than that. I think Germany has health plans and a state-operated system. But it's very important to understand that the United States has unbelievable complexity in its system, which drives up the cost. And, as I said before, we're spending 2.5 times the average of these other rich democracies. And believe me, they're not socialist countries for the most part. They are capitalist countries practicing capitalism. But I'm tied up every night watching Fox News, and that, if you watch them, you'll never get it straight. But I think that we really have to do some deep thinking here, and if we're going to get things right, when you look at how much of our gross domestic product, our economy, is taken up by healthcare. Right now, it doesn't sound like so much. It's something in the, the range of 17 or 18%, but we're still the highest, but it's only 17 or 18%. The CBO did some projections not too long ago, and what they said was, okay, in 50 years or so, if we don't do something, it's going to be 2/3 of our economy. Healthcare is. Healthcare and debt, 2/3 of our economy. What about education? What about highways? What about national defense? All those things are going to be harmed, or either that or we're going to have to raise taxes like crazy in order to keep up with healthcare. We're going to go bankrupt with the healthcare system we have. It needs to change.
Don't go away. Don't go away. The next question, since we've talked about the cost and who has universal health care in their countries, what is the level of health care for the average citizen in the United States versus the people in those countries?
Well, when you look at surveys and so on that have been done, and there are many, these other countries tend to outweigh us. They're doing better in terms of outcomes. They have much lower costs, et cetera, et cetera, et cetera. Now, having said that, I want to make it clear that I think we have the best health care in the world, all right, on the planet. We have the best doctors. Here's one right here. I'm one of his patients, so I know what I'm talking about. Two. And that's right. I'm not Fred's patient, but I know Fred has done a great job, and we appreciate it. But we have the best doctors, the best hospitals, the best medical schools, and the best research in medicine. And I can say that, and then I immediately have to say, but everybody doesn't take advantage of it. In fact, we're the only country that has, 15 to 20% of our population not covered, uninsured. What's that all about? It doesn't make any sense to me. And when you start talking about it, people accuse you of being socialist, a communist, or whatever. That doesn't exactly work with public schools. Do we have a socialized school system? No, we don't say that. But it's publicly funded for the most part. It could stand some improvement, don't get me wrong. Socialist libraries. Yeah. I think we can talk about this. Obamacare can move on, and like I said, I approve of it. But I don't think that we're going to get the fix that we need in the United States. And as long as we're still thinking in terms of employer-based coverage, the reasons why we don't want to cover certain groups, I can't imagine what that would be. But if we keep thinking like we have it right here, and I was amused by the conversation that's going on because it sort of reinforces what I think. Too complex, too expensive. Let's do something about it.
Thank you very much. Marsha, I want to acknowledge the advocate being here. Do you have a question that you'd like to ask the panel? You're good? Okay. No, Bob. Okay. Yes.
I have a follow-up to Mr. Hood. Of the other first world countries that do have universal coverage, how much of that coverage is from private insurance companies or through the private market, which so much of ours is? We're encouraging people to buy insurance policies, which isn't necessarily getting health care.
Well, in most of these countries, I'm talking about the 34 countries in the OECD, as they call it, and in many of those countries, there's no private insurance that I'm aware of. I mentioned, I think it's Germany. Germany has a state-operated system, single payer, everybody's eligible for it, but they also have private insurance plans for those who want it. And, I kind of like that idea, let's have that if people want to pay for it. But, yeah, it's almost all of these countries have very heavy governmental influence, and basically they run the system. They don't own the doctors and the hospitals and so on and so on. They don't do that, but the payment system belongs to the government. Now, having said that, it's a system that's much more simple and uncomplicated. Fox News every night tells me that, well, it's a bureaucratic nightmare. Well, no, it's not. It's simplicity to the max. This is the bureaucratic nightmare, and if you've ever, had to switch from one to another parts of our system and so on, it's really bad. And I'll tell you an anecdote real quick. When I was in graduate school, my wife was pregnant. I didn't have insurance. When the baby came, we took, let's see, I think it was Women's Hospital actually, and I love Women's Hospital, don't get me wrong, but so we went in there and she had the baby. We were ready to check out, and they said, okay, we need to see your insurance. And I said, well, I don't have insurance. I thought we had talked this out before. And they said, well, no, you have to pay us the full amount before you leave the hospital. And so we argued for a while, and I finally said, okay, look, I'll leave the baby here until I go get some money, and when I've earned enough money, I'll come back and pay. And they said, oh, well, so anyway, we struck a deal. But what I'm getting to is, as a matter of costs, who pays the most? Uninsured people pay the most. Unbelievable, isn't it? But, there's a cost associated with, every hospital, whatever happens to you in the hospital, there's a cost. But you don't pay the full cost if you have insurance, because they've already brokered, a special cost for themselves. And, and I'm glad they do, because we have to pay more. But people who are uninsured, they get the privilege of paying out all of it, see? So, not a good thing.
All right.
That's why I would encourage you, one of the things that I've heard people in the medical practice, by the way, I've got 2 doctors, 2 nurses in my family, and I was the first female pharmaceutical rep in the state of Louisiana, is most people don't bother to look at their hospital bill, go over it, and see if it's accurate. They say, well, the insurance is paying it. Well, guess what? We are the insurance that's paying it, okay? So everybody check your bill. And as far as what David was saying about us being a bureaucratic nightmare and them being more simple in these other countries, a very close friend of mine, in fact, a girl that I've mentored, Nicole Coffey, and her husband just moved to England in August. And lo and behold, it didn't take long till one of them got a really bad sore throat. And you know what? They could access a doctor over there quicker than they could get an appointment here in the States. So David's right on the money, and we need to do something about it, but it takes citizens getting engaged. So please consider joining our organization, and we will see you next month on November, well, I don't know the date, but it's the 3rd Thursday, okay? Come see us at that time. Sign up for our emails if you want to know the information that Calder, is it Calder's going to get for me? Yeah, sign up with Rosemary and Mildred and Tanya over there, and we will share the information with you. And thank you so much for coming.